Good quality data is essential for effective planning and health service delivery. But do we trust the data?
Do we trust the data? Systems are only as good as the data we put in. Garbage in, garbage out.
Yeah, I think we trust data when it comes to who really collects the data. So trusting data starts from the source. Hi everyone, welcome to the See It Do It podcast series. See it means see linked data, and do it means act on the data.
Let's make every contact count.
Core concepts and quality improvement.
Doing things differently.
Mentoring, support, supervision, and coaching.
Client perspective.
Data quality, digitization, and linkage.
We are See It, Do It. Welcome to the See It, Do It podcast series. My name is Vicky Doyle. I'm the Quality Improvement Advisor to the See It, Do It programme. Today, we're going to talk about data quality, digitization, and linkage. And I'd love to introduce our two guests for today's podcast series. So actually, can you introduce yourselves, please?
My name is Eric Ejimba. I'm a software engineer by profession. I am with Golden Data.
And I'm Mandela Guche. I work at Lvcthealth and the intervention wing of the See It Do It program.
Fantastic. So we have two people who really know their stuff when it comes to data, the practical implementation of it on the ground, as well as trying to deal with some of this digital chaos going on. So before we start today, I want to start with a provocation, as we always do in this podcast series. And today's provocation is good quality data is essential for effective planning and health service delivery. But do we trust the data? A few reflections before we start.
Yeah, that is an interesting provocation. Do we trust the data? Systems are only as good as the data we put in. Garbage in, garbage out. We'll have more about that.
Yeah, I think we trust data when it comes to who really collects the data. So trusting data starts from the source. If the source is not really good, then of course, just like you said, it's garbage in, garbage out.
Yeah. Okay. Well, let's continue the conversation. So the first question is really about, we've seen a huge change in the country and really it's commendable that the government has gone through this, digitised the community health system, and this is commendable. What have you seen of the benefits of the implementation of ECHIS, which is the Electronic Community Health Information System? What are the benefits that have come from this?
Thank you for the question. So, of course, whenever we introduce electronic systems, there are quite a myriad of benefits. And I think maybe just to start with is the built-in workflows. So the CHPs, they go through the module training where they are taught on how to handle their activities. But then each has built in those workflows within the system itself. So that standardization of the workflows that will guide the CHP from one task to the next, it forms like some guardrails to which we can standardize the quality of care and service delivery.
So it's more than just digital data then. It's actually sort of guiding them through the steps. Is that what you're saying?
Exactly.
Mandela,
Yeah, and
do you
just
want to
to
add
add
to
it,
that?
yeah. It has also given the community health promoters an opportunity to really, sometimes they don't understand what they do, but then the system guides you systematically on what kind of service you need to do and what referral are you supposed to give. So most of the time, in the sense that initially they will just refer without a concrete say service that is needed, say malaria, we can get a situation where all CHPs are referring people for malaria. But then if you look at the system with the systematic guidance from once you get to the household, you assess this particular client, the CHP is able to know what the client needs. And it has also helped in follow-up of the same. Yeah.
Okay.
Yeah, and I think there was, experiences from the CHPs. They were talking about carrying very big books, bulky books, through the household. They move around a whole area, and these books were very bulky. Right now, they just have a phone. Like everything is in there. They can be able to look at the historical data. They can be able to um, systematically visit this household. So they'll know I visited this household yesterday. I don't need to visit it. So the system arranges sort of in planning, helps them plan accordingly, how they move around, how they offer service.
So it helps them plan their day. even.
Exactly, exactly. So with that, they'll be able to know, like, hey, here is a pregnant mother. I need to look at this household. Here, maybe there's a child under 5. Maybe I need to focus on this other one. So in planning, it has really helped a lot. And also, again, moving around, carrying 6 big books versus just carrying a phone, it has really changed the game.
Yeah. So multiple benefits actually. It's not just about digitization and it's about all these other things on top of that just make guiding them through the conversations, helping them plan their day as you said, as well as some of the physical challenges previously.
Yeah, and I think even not just to the CHPs, but also the decision makers, because right now we are getting the data. Okay, so look at it from the CHARs, these are the supervisors. Look at it at the sub-county level, look at it at the county level. So now this data is flowing in every single day, and it's helping make decisions like, hey, maybe we need to prioritize resources to this area, maybe we need more of these commodities, and so on and so forth.
So that leads me really nicely into the next question, which was really about how has this digitization, EGIS, how has that helped in integration and supervision? Because these are really important things. How well the community services integrate with primary care, and whether or not the community health promoters are getting the right kind of supervision as well. So has that helped? Mandela, I'm gonna start.
Take
I'm gonna
that.
start with you,
It's okay.
Mandela.
Let me take it first. I thought Eric will take that one because Eric is the guru in the linkage. So I'll say it's true. It has helped in so many ways. So first of all, I will look at it in terms of in Lvcthealth, putting aside MOH, Ministry of Health, we developed a linkage module app. So this is still a work in progress, and Eric and Tim were the key people who developed this. So whatever happens at the household using the electronic community health information system translates to the facility. So if a CHP refers a client, the facility in charge is able to really see this data real time. So it works real time. Now, the integration part of it is there's a communication between the community and the facility. And the communication is not only for the CHP and the facility in charge, but then there's also a communication. The client also knows that once I go to the hospital, once a CHP refers me, then the nurse will be able to know that I was referred by a CHP. Initially, most of the time we were using we still use them though, but the fact that if you go to a facility and they tell you are referred by this particular CHP means there's a communication between the CHP and the nurse. And these are really brought trust amongst our CHPs with the community people. And then again, it has also helped in decision making in terms of when we are reviewing our data, we can tell which particular villages are actually referring clients in and which ones are not. We're also able to see mothers who have not been followed up because each app has formed a way in which they remind the CHPs with tasks that you are supposed to meet this particular client. It's due time for them to meet an ANC visit. So the ANC nurse can also remember this. So that has worked well. Now, when it comes to supervision, the ANC nurse is able to communicate to the chat where there are issues. If you remember, we chat, So when we're using chat, which is the document that we developed, the ANC nurse, through the linkage module, can also tell a CHP that is not giving proper services at the community level. So they can sit together and have that discussion. So this translates to our monthly data review meetings. Again, we look at the digitalized reports and have discussions on where can we improve and which CHP's capacities need to be improved or strengthened.
Yeah, and I think maybe to add on that, the communication bit has really come out strongly because as a CHP, You are doing work, you are referring clients to the facility, but at times you might not get that feedback that this client I referred, did they actually reach the facility? Did they receive the necessary services? So that feedback loop, which is being powered by the linkage module, has really facilitated that communication channel, two-way communication channel, in that whenever a CHP refers the client to the facility will know, like, hey, there's this list of clients who will be coming in today, and they can plan accordingly. And then once the client has reached the facility and gotten the service, they also get that feedback, like, hey, this client A who went to had been referred to this facility, they received 1, 2, 3, 4, 5 services. And maybe if there is any follow-up activities, again, that is communicated in that message. So that feedback loop has really strengthened the facility community integration. Yeah.
Okay. So I know, we've had this move, and it's inevitable we would move to digitization. And prior to that, there was a lot of paper chaos. We were missing the MOH forms. People didn't know how to fill them correctly. They were losing them. They were then using notebooks, and so very poor data quality.
Yeah.
So then we moved to digital.
Yeah.
But then we've also had quite a lot of digital chaos as well. And we can't deny that. We can't deny that.
Yeah.
And obviously, at the moment, we're working with ECHIS, and then that links to an electronic medical record. What is the challenge of, well, there's the importance of making sure these two systems can speak to each other. And obviously, the EMI may be different in different counties. So how are we getting this linkage really working between the two electronic systems? Because it's not easy, is it?
I like that phrase, digital chaos. And it's true. It's true. We might have some legacy problems we are bringing from the paper side to the digital side. But with the linkage infrastructure, we are trying to minimize a lot of those chaos, in that for those clients that have an identifier, okay, so there is something known as the client registry that uniquely identifies these people. So that information for that client, it's unique to that specific client. So whenever that data is shared with the EMR through that client registry, then there is also another government system known as the shared health record. So that information is for that one specific client. So whether it's the EMR looking at that data, whether it is ECHIS, we are still referring to that same client. But of course, we are having some other mechanisms to just look at the quality of data, to handle some deduplication activities, as well as the other data quality aspects, to just be able to reduce the digital chaos as much as possible.
I don't have anything to add on that. He has mentioned it perfectly.
Yeah. And so I think it kind of, it's really bringing us to this is the final point, that we've moved now to having this whole digitization of the health system. And of course, it doesn't come without challenges. And, I suppose the big question is data quality getting better or not?
Now, I think that is a really interesting question, because number one, we look at, first of all, is the data available? So for us to assess quality of the data, we have to have the data in the first place. And I think the move to digital has really increased the data availability. So right now, we have the data, so we can now start looking at the quality. But now looking at ECHIS itself as a platform, since you're having a client list, so the CHPs have a list of the households. So whenever they are putting in information, they're just adding to that same file, okay? So the information is not scattered across several books, okay?
Yeah.
So aspect number one, since all this data is in one location, we can be able to assess its quality, okay? Now, there are some quality checks that are built in within ECHIS itself. Then there are some other external checks that the supervisor, so the CHARS, as well as the other levels of the sub-county and the county, that they can be able to run against that data. Okay, so the first defense is the rules within each itself, so to prevent garbage from coming in.
Yeah.
And then periodically, so I think right now it's quarterly, I'm not really sure, where these data quality checks are run. Okay, so we compare that with just first of all, cross-validation within the digital data itself. Then there is validation against some paper tools. So there might be some MOH tools, there might be some tools at the facility. So cross-validating across that.
I'll add on that in this sense. For me, I look at data quality from the personnel angle, from the personnel input. I know Eric is talking from the digital aspect.
Yes.
So let me stress this, and I know you want to be happy with me for this. So, from the personnel input, data quality currently, yes, we can trust some, but we cannot be sure about others. Why? Each's platform, which is the electronic communication information system, is new to the CHPs. The capacity of our CHPs is not as, as Eric's or I's. So I think there is need to really strengthen that part of it, the capacity, the personnel, because we have CHPs who may not be able to read well or interpret it. And we might say that CHPs are very good at their work, but they're also very smart. They know how to navigate the ECH system in a way that pleases the system. I know there's this talk about looking at their work and then quantifying it with probably the stipend and stuff like that. So they find a way of, navigating it in a way that they're able to cheat the supervisor.
So we call it,
Yeah,
it's
that's
called,
what-
it's
exactly.
like cooking the data.
Cooking the data.
Yes, because the same would happen with paper systems as well. You can
True,
cook
true.
the data.
Yes. So let me use eaches. Now if you go to an household and click on that particular household and leave, Eric might not know, but then the system will say that is an household visit.
Okay.
Now, it goes back to again, who is the supervisor? What does the chat do to ensure that our CHPs give accurate data? Now, you compare the two. For us, we've found a way of noticing household visitation should really correspond to the assessments made. So you find a situation where a CHP might have 100% household visitation, but then when it comes to assessment of, say, under fives are, say, 20 or 30%, that alone is a quality query.
Raises a challenge,
Yes.
a question, doesn't it? Yeah.
So let's work on strengthening the personnel and strengthening the supervision. So it starts from, do the CHARs know what they are really supposed to look at when we are bringing in this data? The system might not pick if it is data that is accurate. It will pick in terms of age, in terms of demographics, in terms of the service that was given. But it might not pick in terms of what did the CHP do in the household level. So that goes back to the access of this particular data. Eric and Tim are talking about ensuring that sub-county teams, some of the county teams access this data. And this is very important to ensure that we have quality data that is coming in from the community level. And I think this also translates to the facility. Most of our facilities are level, especially level 2s and level 3s. We have one staff in this particular facility. So they first start with the paper.
Yeah.
And then later
This is
key
what
it
they
into
know.
the
It's what they
so
know. Yeah.
then later when there's time, they'll key it in the digital space, and there could be errors in this. So I look at data quality from the personnel part of view, and it's very important to strengthen the personnel so that they can be able to effectively and efficiently use the digital way. So that way we'll really limit the data quality issues that we have in the digital system.
Yeah, because I think there is a tendency to think once it's driven by technology, the quality is going to be much better.
Yeah.
But I think you've explained that really well. That it's not just about having the digital systems; it's people's ability to use it and interpret it and drill down to what that really means. So it requires building the capacity of those supervisors to understand and to pick up if there's any data cooking going on as well. We're never going to be able to avoid data cooking altogether, cooking the data. Anyway, I think, on that note, I think we've had some really interesting discussions about data quality, digitization and linkage. I was thinking this is going to be a really difficult one to make it sound exciting, but I think it's revealed a lot of interesting issues. So let's now, I'd love you to, we like to sum up our podcast with 3 key messages. So over to my lovely guests in the studio today. What's the first key message we've got, Eric?
Yeah, I think the first key message is EACHES has been embraced by the CHPs.
Yeah.
And I will say linkage of digital systems is paramount for integrated service delivery, health service delivery.
Yeah, and I think another message would be a system change. So for us to maintain both the integrity and the quality of that data for decision making.
Yeah. Thank you very much for joining the podcast today. I very much hope our podcast listeners have heard a little bit more and understand a little bit more what we mean now when we talk about data quality, digitization and linkage. Thank you.
Thank you.
Thank you, Vicky.
Let us do it now.